that you can access. Again, this is very, very much required for our accreditation of this series. Dr. Will Dodd for our introductions.
So today it's my pleasure to introduce Dr. Jerry Walkup. Dr. Walkup is, for those of you who don't know, Johnson City's newest pediatric cardiologist. He did his medical school training at Ross University, residency at University of Tennessee, Chattanooga, and his fellowship in pediatric cardiology at Virginia Commonwealth University. He has a keen interest in pediatric dyslipidemia. He has numerous research papers in dyslipidemia, and he's also a member of the National Lipid Association.
In LA.
In LA. So without further delay, Dr. Walkup's going to talk about pediatric dyslipidemia.
All right. Thank you. Can everybody hear me okay? Yes, general okay? All right, excellent. I have no disclosures. I like to walk, so if I'm bothering you by walking, tell me, but I can't stay still. So I think in pediatrics, we have sort of basic understanding of atherosclerosis, dyslipidemia, but it's very basic. It's basically what we remember from medical school and from training, and then we kind of lose it as we go along. So I think in order to talk about pediatric dyslipidemia, we really have to review the basics of atherosclerosis. We have to talk about lipoproteins in general. And then I want to take you kind of into an introduction of the most recent recommendations that the AAP has adopted. And then I want to explain the research behind that to understand why they made these new recommendations. We're also going to talk about familial hypercholesterolemia just as a basics of diagnosis, and then some general treatment options. I'm going to give you a brief glimpse of what may be some future concepts for pediatric dyslipidemia. I'm not going to go into the specific genetic diagnosis. I could spend 2-3 hours on that alone. So we're going to keep it to just kind of the primary care setting. So how relevant is this to our area? Well, if you can see this map, this is actually us. And the darker the color, so kind of the not quite burgundy, sort of mid-red, you know, as a guy, I call this all red, but the sort of not quite darkest red would indicate a prevalence of about 1 in 250 to 1 in 165. So the typical quote with incidence of familial hypercholesterolemia is somewhere about 1 in 250 to 300. And in our area alone, it's actually more prevalent than that. And as you go slightly to our east and you get into the western parts of Virginia, it's even more so prevalent. So this is quite significant to what we do here. We have to go through the basics of atherosclerosis. We have to recall all of this. So elevated ApoB lipoproteins, or the non-HDL, you'll hear me use those kind of interchangeably. So remember that ApoB lipoproteins, these are the lipoproteins that express the ApoB protein, that sort of tag on them, okay? Those are all the ones that are not HDL or non-HDL. Elevations in those lipoproteins plus the endothelial dysfunction, the disruption in normal endothelium, not necessarily damage, which is what we used to say, but the actual dysfunction itself are the combination of events that start this whole process. Then we get into the infiltration of the non-HDL. It goes into retention, attaching itself to the subendothelial basement membrane, and then those undergo modification, inflammation, plaque formation. So what does that look like in picture form? Well, we have on the left side of the screen the ApoB lipoproteins in excess crossing into the subendothelial space, undergoing retention, modification. This attracts mast cells, which then become macrophages, absorbing the lipoproteins, undergoing a change to the foam cell, leading to inflammation, and the cycle continues. When we look at the generation of atherosclerosis over time, all of us as pediatric specialists, we operate sort of on the far left of this screen. We're in the area of the fatty streak formation, the initial foam cell formation. So this is where you and I are focusing, trying to do what we can to prevent the progression into the complex plaque. We talk a lot about LDL, HDL, non-HDL, And we sometimes forget that this is representative of particle. It's not just cholesterol, it's actual particles. So I like to show what the particles we're talking about are. What are lipoproteins? Lipoproteins are a combination of phospholipids that have a core that's made of cholesterol esters and triglycerides. The surface does have a little bit of free cholesterol, but the important thing for the surface are the apolipoproteins. Those are sort of the license plates of the lipoproteins. Lipoproteins have different license plates, and that's how we identify which ones are which. Which ones come from the gut, which ones come from the liver, which ones are chylomicrons, which ones are VLDL, which ones are HDL. So that's important for identification, and it's important in our workup as well. But I want to remember that when we say LDL, we're not just talking about cholesterol, we're talking about these particles. How are they all different? Well, they're different in size. Chylomicrons and chylomicron remnants are the largest particles, and then the VLDL is the next largest particle. It gets progressively smaller as you become LDL. Now, if you look at the difference in the composition of each, the blue, or the top half, is the triglyceride composition. The more triglyceride you have, the larger the particle you are. The less triglyceride you have, the smaller the particle. This becomes very important in elevated triglycerides. So when we have patients who have true elevated triglycerides, this is going to come into play. And we'll talk about that in a minute. The other thing to keep in mind here is that we see that all of the non-HDLs, everything that is not HDL, is atherogenic. So this is why we focus on non-HDL cholesterol and not just LDL. We say the non-HDL is important because you're accounting for the chylomicron remnants, the VLDL, the IDL, all the components that have the potential to cross into the subendothelial space and cause atherosclerosis. How do you calculate non-HDL? Most of our labs are kind enough to do this for us. However, there are still a few that don't. It's a simple formula. Your total minus your HDL. That's it. Nothing magic about it, but that'll give you your non-HDL cholesterol. How do we absorb cholesterol? How do we absorb free fatty acids? After dietary cholesterol is taken in, it then crosses into the intestinal cells. It's repackaged as chylomicrons. So you take your triglycerides, you take your cholesterol, you package them together into these lipoprotein particles called chylomicrons. They're then absorbed through the lymphatic system and go through the process of traveling to the body and eventually ending up in the liver. Okay? The chylomicrons themselves at initiation are very large particles, and are they themselves not atherogenic because they're too big. But as they lose triglycerides, they become smaller. So, and we said the chylomicron was one that was the heaviest in triglycerides. So as they lose that, they become remnants. The remnants are now small enough to be atherogenic. The remnants then recycle to the liver. The liver then repackages as VLDL. VLDL loses triglycerides, becomes smaller, becomes IDL. IDL loses triglycerides, becomes smaller, becomes LDL. LDL recycles back. But all of those particles are small enough to be atherogenic. Another thing that this kind of brings up, why is it when patients are in a non-fasting state, their triglycerides are usually very high and unreliable? Well, what particle has the highest composition of triglycerides? Chylomicrons. It's a 10-to-1 ratio. 10 triglycerides for every 1 cholesterol. VLDL, 5-to-1. So when you have a non-fasting state, your triglycerides are high because there's still some chylomicron remnants floating around, and they take a while to clear away. So that's why fasting versus non-fasting is very important for the triglyceride measurement. So how do triglycerides play a role in all of this? So remember that the triglycerides are the highest component of chylomicrons, VLDL, okay? The bigger the particle is usually related to how much triglyceride it is in it. The more triglycerides you lose, the smaller you become. How does this all play a part here? If you have more triglycerides, more free fatty acids, your liver begins creating more VLDL, the initial packaging of all of that. There's an enzyme called cholesterol ester transferase protein. It's CETP. This is floating around in the blood and allows crosstalk between VLDL, HDL, and VLDL and LDL. What it allows is it allows the VLDL to give away some of its triglycerides in exchange for cholesterol. So what do you end up with? You end up with a VLDL that has more cholesterol than normal and less triglyceride. You end up with HDL and LDL that end up with more triglyceride and less cholesterol than normal. So at first that sounds like, okay, you've made the LDL and the HDL bigger particles than normal, and that's true. The relative concentration of cholesterol in them is slightly less. However, LDL and HDL interact with lipases that exist throughout the body, and they begin to lose their triglycerides. As they lose them, they go from being bigger than normal to smaller than normal, and you end up with small, densely packed particles. How does that matter for HDL? When your triglycerides are high and you have a lot of triglyceride in your HDL and it's lost and it becomes smaller, it now can be cleared by the kidney and you lose HDL. How does that affect LDL? You end up with smaller, denser LDL. If your liver is working in front of a conveyor belt and it's reaching out and trying to grab all of the LDL as it passes by, if they're large particles, you can grab that pretty easy and pull it out. The smaller the particles, you can try and grab them, but they may miss you. They may go by too fast. They may be too small to reach out and grab. So this is why triglycerides being high usually drops your HDL. It may not affect your LDL measurement, but it's increasing the particle number and decreasing the particle size. This is something that we're looking at with the future of how we're measuring these things. So I just want to give a brief glimpse of the current recommendations and talk about their significance. So 2011, we had new recommendations made about how to screen in pediatrics for dyslipidemia. The big change here was universal screening. Universal screening had not been done before, it had not been recommended before, and now we were recommending it in 9 to 11 and 17 to 21-year-olds. So that was a very big change. So the question became, why should we do that? What is important about that? Well, the paper that initially stated all the recommendations mentioned that, yes, atherosclerosis, it begins in childhood. There are risk factors that we can identify in childhood, they track into adulthood, and we are missing a significant number of patients with a selective screening process. Now, by selective screening, I mean you're deciding to draw blood on patients based on history, based on their exam. That's how you decide. So, why did we say that? Well, the paper cites several key papers about research in pediatric dyslipidemia. This is a whole list of them. I'm not going through all of them, but we're going to touch on a couple that bring up some good points. So this is the one called the PDAY study, Pathological Determinants of Atherosclerosis in Youth study. This was an autopsy study of young people who died from external causes. Okay, what they did was they looked at risk factors based on their specimens, and then they looked and stained the coronaries of these patients. And they said, we know that fatty streaks occur in young people. There's research that predates this study from people who passed away during wartime who were autopsied, and we found fatty streaks. They said, that's great, we know fatty streaks exist. Oh, it's not great, but fatty streaks exist. But do fatty streaks become fibrous plaques? Or do fatty streaks, are they just fatty streaks and they never do anything? So what they ended up doing was looking at the coronaries and the distribution of fatty streaks, which is on the left side of the screen, over time. What we found is that as you age, fatty streaks increase. There was not much of a surprise there. On the right, that's the raised plaques, the fibrous plaques. And what they found is the areas that are darkest on the left side of the screen ended up being the areas where fibrous plaques associated. So where fatty streaks were more concentrated, the fibrous plaques eventually developed. So this was important because it says, yes, these fatty streaks actually do matter. This is another study. This is looking at the Muscatine study. This is from the 80s. What they did was they looked at children and they followed them into adulthood, remeasuring, and they started at around the age of 7 or 8. They remeasured cholesterol levels over time and eventually checked them when they were 25, 26 years old, in their 20s. And what they found was they were trying to associate how much of your cholesterol in childhood determines what your adult levels will be. And there was an association. There was about a 30 to even sometimes up to 45, 50% association between your cholesterol as a child determining the cholesterol as an adult. This is another study. So we have a hard time in pediatrics because it's hard to follow somebody for 50, 60 years. So we have to use surrogate markers. So one of the surrogate markers that a lot of people use for coronary artery disease is carotid intimal thickness. Basically, you do an ultrasound of the carotid artery, you measure the thickness of the intima, and that determines how severe your coronary artery disease risk score is. So a higher thickness is worse prognosis. So this study was actually looking at people who had measurements of carotid intimal thickness and had had cholesterol levels analyzed and risk factors analyzed as young people. So at the bottom is the 1986 risk score. So you had a child in 1986, you measured the risk score, and you said your initial risk score is this, based on your obesity, family history, your cholesterol, do you smoke, all of that. As you go toward the right side of the screen, the risk scores for 1986 increase. So this is looking at carotid intimal thickness measured as an adult, basically 15 years later. And each bar for each group represents whether your risk score went down as an adult or up. And what you'll notice is that as your risk score goes up, as you move toward the right, as your risk score got worse as you aged, yes, your carotid intimal thickness also got worse. That was expected. But what they found was that if your 1986 risk score on the far right of the screen was high, you were a 5 to 16 point risk score, you had a lot of risk factors, your risk as an adult, even dropping down 12 points on the risk score, was still higher than people who had a low risk score in 86 to begin with, even if those people got worse with time. So it said here in this study that your pediatric determinants, even if you improve, may still be hurting you in the long run. So this said we can't wait. What did the Framingham study tell us? Well, they kind of told us some information on what should we be measuring. Should we just look at LDL? Should we just follow the classic bad cholesterol? And they looked at patients with LDL and non-HDL, and they said, what's your relative coronary vascular disease risk? Well, if you look at the frontmost bars, the yellow ones, as your LDL goes up, yes, your cardiovascular risk goes up. But if you track the non-HDL, it's actually more significant, and it tracks closer to your overall risk. So this was an interesting idea. And they did the same thing with triglycerides. And they said, do triglycerides matter? Well, if you track LDL, which is represented by the kind of forward and back on this, the orange and the gray, or the blue to the gray. I hope no one's colorblind. If so, the front ones and the back ones. As the LDL goes up, yes, your risk score goes up. But look at what happens if your LDL stays the same. That's the blue to the orange. If your LDL is unchanged and your triglycerides are high, your risk is just as much if your triglycerides are normal and your LDL is high. They're both equal risk factors. So this said, hey, triglycerides are playing a real important role here too. We have to follow these. So the big thing about this was we picked 9 to 11 years old, we picked 17 to 21 years old, we said those are the universal screenings, and everybody goes, why that age? Why'd you pick it? That was random, right? It just came out of the air. No, there's a study in the 80s that told us when we measure consecutive numbers on cholesterol, there are peaks. Your peak is right around 9 to 11, and then you reach a second peak in the 17 to 21. So the question became, why is that? And the answer is puberty. You use cholesterol to make the hormones of puberty. During that time period, the cholesterol will artificially be lower, and therefore it's maybe a false negative. You're saying the cholesterol looks great. Remeasured at 17, oh, it's not so great anymore. So this is why that time frame. The idea was to not measure during the time of puberty. This one, I'm going to skip this one because I really want to go to this one. This was the one that really kind of put a footprint on why we should be doing a universal screening strategy. This was a big study, 20,000 patients. They basically screened all of them serologically. Everybody got a blood draw. On the left side of the screen are the patients who would have had a blood draw if they had based it just on history. So I take your history, I take your risk factors into account, and I say, yes, you need serologic testing. And they said, okay, 70% of you meet those criteria. 25% no, you don't meet those criteria. But they drew everybody. So what did they find? Abnormal LDLs in about 8% to 9% of both populations. Okay, what's the big factor? What's the big take home here? If you look at those abnormal LDLs, they broke it into people who had very abnormal LDLs as a fasting with LDL greater than 160. They could have used a different cutoff, but they used 160. And the people who were not 160 but were abnormal, people you might have not considered pharmacological therapy at the time. If you compare those groups, how many patients did we miss that were just based on selective screening by just doing that strategy? How many patients would have been missed? It's a third. We missed 33% of patients who had abnormal cholesterol just by selective screening strategy. Well, how many of the, okay, so that's fine. Maybe they were all 125, 135. Maybe they were just slightly abnormal. How many were so abnormal we would have considered pharmacological therapy? It's a third. We may have missed 1/3 of patients with LDL so significant you might have considered starting therapy for them. So they said, this is a big miss. This is a large number of miss. So clearly the current selective screening strategy isn't working for us. We need to do something different. So this is one of the big studies. There are a few others, but this is one of the big ones that said 33% at least are being missed. There are studies that quote higher numbers, 60%, 40%, but this is the biggest. So let's go back to the current recommendations and talk about them. So in the birth to 1 year age range, there's really no good solid recommendation for lipid screening. It's very challenging. They often have abnormal triglycerides because they're fed constantly. It's hard, you can't really get a good fasting sample from them, so the triglycerides are pretty much going to be hard to find. There are going to be selective patients that are going to be very rare and very abnormal, but in general, there's no routine screening. 2 to 8, no routine screening, but you can employ a selective strategy based on these risk factors. If they have a first or second degree relative with early cardiovascular disease. Now, I like to point this out. What's early cardiovascular disease? For men, less than 55. For women, less than 65. Okay, but what is cardiovascular disease? It's not just a heart attack. Angina, stroke, stent. A lot of people, if you say, hey, has anyone ever had an early cardiovascular event? All they think is MI. And so they know, no, but dad has 3 stents. That's significant. So you have to clarify it. So you have to really broaden it to say, has anyone had a stroke? Has anyone had a cardiac cath? Has anyone had any kind of intervention? Or does anyone have angina? These are things you have to qualify. If you have a parent with a cholesterol that's greater than 240 or known dyslipidemia, most parents don't know that unless it's truly abnormal. If you have a patient who has diabetes, high blood pressure, BMI greater than 95th percentile, or is hopefully not at this age as a smoker, but it's on there. If the kid's a smoker, you got a lot of other issues to deal with. But there are some moderate and high-risk considerations as well, and we'll go into those. 9 to 11, universal screening strategy. And how do you screen? You can use a non-fasting sample, and the non-fasting sample will be looking at the non-HDL. The triglycerides are going to be hard to interpret, most likely going to be high. You're looking at the non-HDL. You can also do a fasting sample. That's perfectly fine. But you need to qualify which one you're going with. 12 to 16, puberty. There's no routine screening. You can still use the selective strategy that you used from the 2 to 8-year-olds, but they drop the BMI percentile to the 85th percentile. 17 to 21, they recommend, again, universal screening strategy. What are those high-risk conditions? High-risk conditions would be hypertension that requires therapy, a smoker, and obesity greater than the 95th percentile. Moderate risk would be people 95 to 97th, hypertension who's not on therapy, or if somehow you knew they had a low HDL already. What are the special conditions? Well, diabetes we already talked about, but it's both type 1 and type 2. Chronic kidney disease, end-stage renal disease, renal transplant, heart transplant, Kawasaki's with aneurysms. What about the moderate risk category? Kawasaki's that had aneurysms that went away, or chronic inflammatory diseases, nephrotic syndrome, HIV. So Kawasaki's disease, you had an aneurysm, it went away, you are considered moderate risk. Here are your cutoffs. These are in publication, you don't need to write them down or anything. So they give you cutoffs for total cholesterol, LDL, non-HDL. The nice thing is they actually gave us a cutoff for ApoB. This isn't something I expect the general practitioner to be doing. This is something I expect your lipid specialist to be doing. Triglycerides, important factor here, it's got an age discrimination. 0 to 9 versus 10 to 19. There is an age difference in that. So you do need to know what age you're obtaining this at. The HDL has a cutoff. ApoA1 also has a cutoff. That's more investigational right now. This is a busy slide. This is your algorithm. This is what I post right next to my desk. This is how I follow each patient and try and figure out what to do. You have a fasting lipid profile you've obtained on a patient or a non-fasting. What's the first thing you're going to do? You're going to repeat it to make sure it's true. What's the time frame for repeating it? 2 weeks to 3 months. That's generally the time frame I use for repeats. When you have 2 fastings and they are both abnormal, average them. That'll tell you what risk category you're going to go into and what basic algorithm you're going to follow. If the LDL is greater than 250 or the triglycerides are greater than 500, the general recommendation is a lipid specialist should be involved. These are patients with most likely a genetic diagnosis who are going to require pharmacological therapy early, and they're going to have a lot of problems. If they're in anything lower than that, then you basically take a division of whether it's the LDL that's the problem, the triglycerides that's the problem, or which one you're going to target first. So this is the algorithm for LDL. The triglyceride one looks very similar, except the bottom half is different. The first thing you do is you evaluate for secondary causes. We'll go into that in a minute. And you try diet modification. Child 1 diet, I'll show you that as well. And then eventually the child 2 diet, depending on how well they're controlled. You repeat the fasting lipids after a period of time. There's no good recommendation on when to do that. Some people use 6 months, some people say 3 months. I tend to go a little bit longer. It just depends on the patient themselves. So it's patient specific. Then, at repeat, what is the LDL doing? If the LDL is 130 to 190, there are no family risk factors, there is no risk factors in the patient, you can continue with diet and just continue to monitor. The rest of this is remembered to be a guideline. This is not a law. This is something that's supposed to help you and give you suggestions. They would suggest that an LDL greater than 190 probably should be treated with statins. That's likely to be significantly abnormal and hard to treat. LDLs in the intermediate zone, it depends on how much of those risk factors we talked about that you have and how much family history contributes. So those basically you decide whether I'm going on statin therapy or we're going to continue to try diet modification. This is the triglyceride one. Very similar at the top, everything's the same. At the bottom, it divides it out into the triglyceride therapies. Basically, if you end up in that intermediate zone of triglycerides and you don't know what to do, things you can do besides the child 2 diet is talk about fish in the diet, how much fish is somebody eating. You can talk about fish oil supplementation. We'll talk about that in a minute, but there are ideas of what to do based on those numbers. What are the secondary causes of dyslipidemia? What are the things you should be evaluating when you first get those abnormal levels? These are pretty much most of them. So you have them broken down here by what their etiology is, by organ system, inflammatory disease, exogenous. Medications is a big one, and it's one we often forget. One of the big medication groups that we have to think about is contraceptives in the female patients. That's very often one of the causes. The way you prove it, you take them off the contraceptive, you recheck, and it's normal. Simple, quick, easy fix. You're a magician. You take the risk of pulling them off a contraceptive, though. So these can help you determine what your workup will be. There's no standard workup that you can do every single time, but this can guide you. Strong family history of thyroid disease, check the thyroid hormone. I check those in most everybody. Strong family history of other things, you can focus it based on how the patient presents to you. This is a little challenging for me to read, so I like this one. This tells me what is my abnormal lab, and therefore, what should I be thinking about? So if your cholesterol is high with high HDL, these are the dietary, drug, disorders of metabolism, and diseases that can cause that. If my HDL is low, there are my causes. If my triglycerides are mildly high, there are causes to think about. If the triglycerides are excessively high, greater than 1,000, these are things to think about. So I find this one a little bit more helpful. All right, so let's say you have a patient and you think that you have a true diagnosis of familial hypercholesterolemia, and you want to know if it's real or not. There are basically 3 really good algorithms you can use. These are basically score calculators. They're all online. You basically just search for them. The Simon Broom and the Dutch lipid one. Those ones use exam features, patient's own cholesterol, known family history. Genetic testing is a factor, but not a requirement. The last one, the MedPed, actually just uses the patient's cholesterol and family history of FH that is diagnosed. So you can use the exam features if you notice that they have the corneal arcus, the little ring of white that's just around the cornea. That can be a big feature to tell you. You can use the tendon xanthomas. The most common places for that are the hands. So what I have patients do is they make a fist, and I look for irregularities, kind of bumps, lumps on the knuckles or anywhere along those tendons. And then the Achilles tendon is the other big one, and that's sometimes subtle. So I advise everybody to start palpating Achilles tendons to get an idea of what normal is. Abnormal is either something obvious, where it's a large mass hanging off the Achilles tendon, or it'll have kind of a rope feeling, like not skinny, something you could climb. So that's my little trick. What's the Child 1 diet? Okay, so the basics of this one are avoid sugary beverages, encourage water. There are cutoffs for fat. This is hard for parents to understand. So this is where your nutritionist really becomes your friend and can really put this into good terms for the family that they can understand. But this is the bottom lines of it. Saturated fats should be reduced, avoiding trans fats, encouraging mono and polyunsaturated fats to be the fat composition, limiting cholesterol, high fiber foods, teaching about portions, teaching about exercise, teaching about sodium. And then if you need to go to Child 2, then you can look at the different versions. Now this is just a sample menu I pulled off the internet. So there are various versions of sample menus of the Child 1 diet and Child 2 that you can find at different places. But this is something that really needs to be built up better, because parents just don't understand when we tell them these numbers. And I don't think, as a patient myself, I would understand if you told me 25-30% of your fat, that's how much of your diet. I don't get that number. I get the Whopper. So these are the don't buy that, don't do that. The recommendations, Child 2 divides into LDL and triglycerides. So if you're LDL focused, it tightens up your saturated fat component even further, and it decreases your monounsaturated fats a bit further. The cholesterol also gets tighter. The triglycerides, a real focus on decreasing excess sugar, because you don't want to have the insulin resistance that can go with this. You don't want to encourage the triglyceride formation, and dietary omega-3s. So there is a list of dietary omega-3s that's online. It's very searchable, and it breaks it down by type of fish. So I often ask patients, what kind of fish do you like? A lot of people say tilapia. That's the lowest concentration of dietary omega-3s. Trout is a little bit better. Salmon is much better, but patients typically, at least in this region, don't seem to like salmon a whole lot. But tilapia seems to be very, very happy like one. But you can tell them what ones they can do, but in some cases it's just about substitution. So you don't have the Whopper, and you don't have a fillet of fish, but you have a baked fish. So it's about substitutions just as much as about omega-3s. So what are the pharmacological therapies? So you've decided this patient needs to start pharmacological therapy. What am I going to do first? I'm going to obtain the CK, AST, ALT as a baseline. I want to know where you start, because when you come back, I want to know if these numbers are going up, down, or staying the same. So this is what I get at the baseline. What are the various medications I can choose from? Okay, so there are lots of groups here. There are the statins, there are the bile acid sequestrants, fibrates, ezetimibe, and finally omega-3s. This is the effect each one of them has on the various components in general, as far as the range of all the medications. As you can see, it's a wide range of statins. They have a large effect on LDL. Bile acid sequestrants, more focused on LDL. That makes sense. Bile acid is made of cholesterol. Fibrates, ezetimibe, kind of goes through the list, but we'll go through each one and touch on them. But this is just for your reference. If I'm starting a medication and I want to focus on one specific thing, I want to know which one is going to do the most bang for the buck. Statins, HMG-CoAce reductase inhibitors. What do these do? At the bottom of the screen, you see the number 1. That's the actual action of the statins. It inhibits your natural production of cholesterol. By doing so, it increases the production of the LDL receptor. So your body starts pulling more of the cholesterol into the liver because it's not making it. In addition to that, it inhibits the production of the VLDL because there's not enough cholesterol around to start packaging it. And then it may also increase the production of some other factors. But these are the basic forms of it. Now, what are the statins that we have to choose from? The nice thing is they all end in statin. It makes it very easy. But they're very different. The only one that's approved less than 10-year-old is pravastatin. These are general starting doses and max doses. You should check with whatever reference you use, but these are the ones that are generally published. But the other things you need to realize about them is their half-lifes differ, and their solubility differs as well. So the solubility really comes into effect when we talk about side effects. So we know that lipophilics tend to have a higher association with myalgia and myositis. So we typically like to use hydrophilics if patients have those problems. It doesn't mean you have to start with a hydrophilic. This also means if you have a patient who presents with myalgia and myositis, that you don't have to say, okay, no more statins, we're done. You can try the different groups. You can try the different half-lives. The other thing you can figure out is, do I have a patient on a medication that uses any of these cytochrome P450 metabolites? If it does, this may not be the statin for you. If the patient has a reaction to the statin, as the muscle pains, try a different cytochrome P450 pathway. That might be the solution too. What are the side effects? What are the issues that we run into? Transaminases getting elevated, that occurs in about 3% of patients. Muscle complaints is quite variable. It's anywhere from 1 to 10%. Some patients complain of fogginess, kind of mental clouding. It's rare. Drug-drug interactions, and of course, category X for pregnancy. So you have to really educate your females who are going on this medication about that risk factor. What are some of the potential interactions? I've started the patient on a statin. What drugs do I need to be mindful of? It is statin specific, but the drug list is quite expansive. The azoles for the fungal infections, erythromycin, clarithromycin, so they're antibiotics. Cardiovascular, amiodarone, calcium channel blockers, HIV medications, transplant medications, other cholesterol medications. Gemfibrozole is notorious for this problem. So let's say you have a patient. You've decided to start them on a statin. They come back to you and they start complaining about muscle pain. They say, my muscles feel achy, and you're like, I don't know what to do. Is this a reaction to the medication? Is this something I need to treat? The National Lipid Association and actually the ACC have both tried to help you out with this. The ACC actually put out an app for your phone, and the NLA has a nice downloadable paper from their website. They break it down into defining what myalgia, generalized achiness, myopathy, true weakness, myositis, breakdown, myonecrosis, significant breakdown, eventually leading to rhabdomyolysis. They have definitions for each of those, and they have a risk score. So you tell them, how long have you felt it for since starting the statin? What are the areas that are involved? The higher your score, the more probable it's related to the statin. Well, then what do you do with that information? They have an algorithm. This is very small print, so the bottom line of it, you can remeasure the creatine kinase, you can remeasure your CK, you can see how it is with their muscle complaints. You can then decide whether you need to pull them off the statin or not, but you can always try to pull them off the statin. And in general, if you're not sure, that's the best idea. Let the statin wash out. Give them a period of a few weeks, recheck levels, recheck symptoms. If everything is looking better, you can try the same statin at a lower dose, another statin in another group, or you can try a longer acting statin in an alternate day therapy. 1 day on, 1 day off. And you repeat the cycle. And basically, until you've truly failed 2 to 3 statins, you don't have to consider the whole category non-usable. But this is an algorithm from the NLA, the ACC. It's an app. The app is excellent. It's a little hard to use just because it is a lot of questions, very clicky. You have to click next page, but very good app, and it's free. The NLA also released this with their statin task force, and they said, how likely is it that your drug is going to cause an elevation in CK at various doses? They found that there are the long-acting drugs having on the x-axis the LDL reduction by the dose. The doses are above each little point on the line. How much does that raise the CK? Long-acting drugs like rosuvastatin and atorvastatin, they have very good LDL reduction with not so much elevation in CK, even at higher doses. But when you get to drugs like pravastatin, simvastatin, dose increases actually have quite a significant increase in your overall risk. So if you're increasing those drugs, it may be a thought to actually change drug class. So you're doing the statin, you've decided on it, you're doing lab monitoring. What do you check? Well, you check your transaminases, you're checking your fasting lipids, you're checking your CK if complaints are coming, and you say, okay, we've initiated it 1 month later. I generally do about 1 month to 2 months, more like 6 to 8 weeks after the statin is started, as long as there's no complaints. Recheck those labs, looking to see if the AST, ALT have climbed, to see if the cholesterol levels are starting to lower, and then adjusting dose as necessary. In general, the recommendation is checking these every 3 to 4 months after you've hit a good stride with a therapy. Some people are doing less. In the adult world, they're not checking it at all. So it's variable. But we're not in the adult world. The one thing for us that you need to remember is not only monitoring BMI and growth, sexual maturation. We're driving down cholesterol potentially in a time of puberty. Puberty is when you're using your cholesterol, so you want to make sure the sexual maturation is progressing normally. All right, what about bile acid sequestrants? Well, there's one in peds, makes it easy. It's generally approved 10 to 17 years old, comes as a powder. The bile acid sequestrants activate at the bottom portion of this slide where they bind the bile salts and prevent the reabsorption. Bile is less reabsorbed, therefore the liver says, where's all the bile? I need to make more. It uses up the cholesterol and starts creating more bile, which is then lost, and that's how you get the lower cholesterol levels. Most of the side effects are related to GI discomfort, and they may affect the absorption of other medications, so timing is a concern. Fibrates. There's no good studies of fibrates in pediatrics. Do people use them? Yes, but there's no good studies. The one thing I will say about fibrates, there are two that generally people use, fenofibrate and gemfibrozol. Gemfibrozol has a 15-time increased risk of developing elevated CK levels compared to fenofibrate. If you're going to pick one of the two, I would probably pick the fenofibrate. But I'm not endorsing that because that's not approved for pediatrics as of yet. Disclaimer. Ezetimibe. Ezetimibe is approved in pediatrics. Older than 10, the starting dose is 10, the max dose is 10. That's pretty easy. The ezetimibe, so that acts on the upper portion of this at the sterol transporter. It's the Niemann-Pick-like receptor. And basically, it inhibits the function so that cholesterol is not absorbed from the diet. The one thing I'll go ahead and point out on this, because I didn't put it later, a lot of people will encourage plant stanols and plant sterols in the inhibition of cholesterol absorption. This is how it works. It basically prevents the bile acids from emulsifying the fat globules, so therefore they don't absorb it. Omega-3s. This is the next big one. These are prescription omega-3s. So we tell them all the time about dietary over-the-counter omega-3s. Most of those dietary ones are not regulated, and if you look at the dose of the omega-3 on the bottle, you have to tell the parents, don't look at fish oil, because fish oil will say 1,200 milligrams, look at how much omega-3 is in it. The omega-3 is anywhere from 300 milligrams to 600 milligrams. The typical dose in an adult for omega-3s is between 1 and 4 grams. So they have to take anywhere from 4 to, at minimum, to 10 to 12 pills once or twice a day in a dose of medication that kind of causes bad breath, indigestion. Generally, patients who are going on fish oil supplementation, if I feel like it's necessary, I may consider prescribing it. That said, it's not something that's approved in pediatrics as of yet from the prescription standpoint, but it is something that's over the counter. You can try it. What do omega-3s do? They may have some effect on the release of free fatty acids. They may have some effect on decreasing lipogenesis. They may affect the ability to build triglycerides in the liver by inhibiting the enzyme that attaches each fatty acid to the glycerol backbone. It therefore decreases VLDL production. It may actually decrease ApoB protein production. This is the same thing, kind of said a different way, but it inhibits the release of the fatty acids at the adipose tissue, decreasing your raw fatty acid, decreasing your lipogenesis. So it has some effects. There's also anti-inflammatory effects. It has a lot of good effects. So where are we going with all this? As far as the future in pediatrics, it's really uncertain. We usually lag about 10 to 15 years behind the adults, which is pretty much true for everything in peds. But we may be doing more with the ApoB protein measures. We may be looking to actually count particles because, as I said, with elevated triglycerides, you end up with those small, dense LDLs. So that actually holds higher potential atherogenesis than just having normal sized particles. You also end up with lower HDLs. So particle counts may be coming into effect. If carotid intimal thickness could get standardization, we may be having better surrogate markers of coronary artery disease to where we're doing this in pediatrics and going, your risk score based on your cholesterol, your blood pressure, your BMI is this, much like how the adults have a percentage risk score of cardiac events. So that's something that may be going there. And the expansion of our drug treatments. And I want to talk just for a minute and show a quick video on the PCSK9 inhibitor, because in pediatrics, I don't think we have a good grasp of what this is or how it works. And yes, it's in Russian, but we won't be listening to it. I'll be talking you through it. Of course, if I can get the mouse to go on the picture.
The liver is the gatekeeper of plasma LDL levels and is responsible
Did I mention I don't
for
like
clearance and catabolism.
There we go.
Hepatocytes express LDL receptors that bind LDL.
So LDL binds to the LDL receptor in the hepatocyte.
The LDL
Clathrin-coated vesicle brings it in. Clathrin dissociates. LDL attached to its receptor gets pulled into an endosome.
These vesicles fuse with
The LDL
endosomes,
dissociates.
and the acidic environment of the endosomes facilitates
And now the LDL receptor
dissociation
and LDL
of
are
the
separate.
LDL
The receptor
complex.
gets recycled, gets taken back up to the surface to capture another LDL particle.
Where it binds to additional
So let's skip
LDL
ahead just a
particles,
touch.
leading to a further reduction in plasma LDL cholesterol.
Doesn't look like it's going to let me.
Free LDL and endosomes
LDL taken to the lysosome,
and
broken
degraded
down,
into lipids, free fatty acids, and
recycled,
amino acids.
utilized for whatever. PCSK9, long name, I'm not going to try and say it. It's a protein actually created by the liver, goes through some folding. I really wish this would let me fast forward. It's really pretty, I guess, I don't know. Goes through the endoplasmic reticulum, goes to the surface of the hepatocyte. It then finds the LDL receptor and attaches to it. So now you still have LDL. It comes in, it binds the receptor, now with PCSK9 on it. But now, because the PCSK9 is on it, the LDL receptor can't let go and be recycled. So it's broken down and destroyed. So this was interesting. We found that PCSK9 actually is designed to break down LDL receptors, meaning if it wasn't there, potentially LDL receptors would be more numerous. We found this out because there are patients with a PCSK9 dysfunction. They basically don't attach the PCSK9s to their LDL receptors. They have a loss of function. In those patients, cardiovascular risk scores were incredibly low. And it was because they were clearing LDL and not losing the receptors. So some very smart and savvy people said, well, if we could just prevent the PCSK9 from attaching to the LDL receptor, then the LDL receptor would get recycled. So they said, why if we had a monoclonal antibody that could attach the PCSK9 and prevent it from happening? Boop. I added the sound effect for y'all. So now it can't attach, and the LDL receptor is unfazed. Now when LDL attaches to the LDL receptor doesn't get broken down, it gets recycled, and there are more receptors. That's the idea behind it. Very interesting medication, very interesting strategy, very interesting overall. And that's pretty much the end of what I have. Those are my references. Any questions about anything? Was I too long? Yes.
Excellent presentation. I was just wondering, is there much outcome data in terms of treating these kids with statin, just over the course of time about how many MIs or strokes you're going to prevent at an early age?
It's a good question. It's the question that we get the most often. And the answer is, of course, no, because the studies are going to have to be many, many years long. So the best thing we have right now are surrogate markers. We do have studies that go out 5 to 10 years looking at side effects of statin therapy in pediatrics to see if there is anybody who's having more significant issues related to the drug. And generally, those have been no worse than the adult population. But again, those are short studies. So yes, it is a concern. How many patients with high cholesterol do I need to treat in order to prevent an MI? And the answer is we don't know. But this is something that is going to be very beneficial to know in the future. It's just hard. You're going to have a many-year study. You're going to have to go out until these people are 50. Other questions? Yes?
From a Gen Ped standpoint, you mentioned if you get abnormal levels, wait 2 or 3 weeks and then repeat them again. And then there's no real guideline to when you would repeat that. Is that correct? Is that what I understood you to say? And you can pick a number. You can say 6 months or a year or...
So you have a patient who has abnormal cholesterol on the first fasting sample. There is a guideline, like we said, for 2 weeks to 3 months to repeat that, to double check to make sure it's true. Once you have that and you've decided you are truly high, I'm going to go ahead and recommend dietary intervention. There is no set in stone recommendation. In general, most people do not let that go longer than 6 months. And that's, in general, what I do. And it depends on the patient themselves. If I think this is a patient who truly takes to heart what I'm saying and doesn't have a whole lot of other comorbidities, I'll give them longer to try and encourage them that things have been proved with real diet and exercise or, true modification. If I feel like this is a patient who's not as tuned in, who's family's a little bit more dismissive of what I'm saying, I may follow them sooner. It puts in their mind that this is real and this is not getting better and that they should be concerned because I'm concerned. But there is no hard and fast number. In general, I use anywhere from 3 to 6 months depending on the patient. Other questions? Yes?
I'm an endocrinologist, so I see a lot of the high-risk people. So I feel like I'm in a constant state of ordering lipid panels.
Yeah.
And I'm sure, as you know, there's kind of different thresholds for people with diabetes in terms of when, like, their goal for their LDL is less than 100 and all those other things. But I'm always struggling with when to pull the trigger, start a statin or some other therapy. And I'm also struggling with the fact that we live in an area where most people don't follow through with my dietary interventions. And so I feel like I could almost start putting statins out like candy at my front desk, but I try not to.
Yeah.
So I'm just wondering, and then my follow-up to that is, do you have a preferred statin?
A preferred statin.
For those high risk?
I'll address the second question first. Technically, I'm not supposed to have a preferred one, but I do like the longer acting agents because they tend to be milder and they tend to have the least increase in CK, so your rosuvastatin and your atorvastatin for those cases, because you can get higher on those doses with not as much an increased risk of CK. The simvastatins and the pravastatins, the low dose ones, I use for kind of patients who are teetering on an edge that I'm not thinking that I'm gonna have to go high on these doses. But yes, the higher risk ones, I typically use long actor ones because of the decreased risk. As far as, it's interesting because in the adult world, they kind of did away with the numbers. They're now like basing it on your overall risk score, and they're saying, don't start a statin with a goal of lowering it this much. If they have this risk score, you do a moderate dose statin, and then they do a high dose statin, and then there's the ACC arguing, going, no, we need to give people a number, and it's kind of interesting how that's changing over time. Is when to pull the trigger on the higher risk patients. Those are the ones where if they are, I kind of still use the general numbers. I don't typically use a lower cutoff necessarily for LDL or for the non-HDL. I still tend to use the traditional numbers, but I use lower cutoffs for starting therapy. So let's say you have a patient who's 130, let's say they're 145. So it's not too much above normal, but it is above normal. If they have a high-risk condition, I'm more likely to start a statin than somebody who's not. So if they are 145, perfectly healthy otherwise, they're non-diabetic, they don't have any Kawasaki's history, they don't have a bunch of other comorbidities, their family history is completely benign, I'll be likely to watch that patient or start a low-dose statin, maybe later if the number creeps up. High-risk conditions, I'm more likely to say, no, we're going to start. But I don't use a different number. I typically use the same numbers. It's just my threshold for actual starting therapy. Yes, Dr. Mehta. That's my boss.
For many years, I have used anyone LDL 190. Absolute 190.
Mm-hmm.
More than 10 years, start the treatment.
Mm-hmm.
And that is recommended
Mm-hmm.
by AAP and other associations. The second guideline is LDL 160 and 2 risk factors.
Mm-hmm.
Start the treatment.
Mm-hmm.
Then there are other issues where you will start 150, but for general purpose,
Yeah.
that guideline is pretty good.
It actually is well published in the guideline to where how many risk factors count. There's always the physician nuance, there's always the vibe you get in the room, but there are strict bullet points for it. I do tend to follow those in general, but there is something in the room, there's a vibe you get in the room, there's a vibe you get from the history. You use the ADA ones?
So the problem is the ADA guidelines are much stricter.
Yeah, they are.
And would suggest treatment at much lower levels. And many people in pediatric endocrinology are treating due to those guidelines at lower levels.
Mm-hmm.
But I find myself, especially in this region, struggling with that recommendation because, again,
You'd be putting it on everybody.
a large portion, and a lot of my patients are taking their insulin anyway. So I'm like, are you going to take your statin? But so I'm always trying to fight the battle of what am I going to achieve.
Yeah, I typically, that's absolutely true. The ADA guidelines are much tighter and much more strict. I don't follow those, and that's in general. I use these, and I find these, they're, like you said, they're less strict, but I find them to be something that I end up putting less people on and allowing to watch a little bit more than I would if I was on those guidelines, I'd be treating everybody, especially here. No offense. Other questions? Everybody's an expert at lipidology now. Hooray!